Today, the topic of discussion is on the anomalies of the kidney. We'll go in some detail regarding the anomalies of the kidney, but not the ureter and the bladder and the urethra, etc. Because upper urinary tract and lower urinary tract, although developing from the same sources, have different kind of presentations. So therefore, I limit myself only to the anomalies of the kidney. The other parts I will cover later. However, you must have realized by now that we have covered some aspects of the anomalies like PUJ obstruction and the uretrovesical reflux, etc., etc. So therefore, there is some overlap, and I will look into that in the next presentation. The anomalies of the urinary tract, they go by the term of CAKUT, that means congenital anomalies of kidney and urinary tract. And in today's time, they are one of the most common causes of prenatally diagnosed developmental malformations. This is now becoming the practice, that prenatal ultrasounds will give us a very good idea of what are the anomalies the parents are likely to face, and you as a surgeon are likely to face. And they outline a spectrum of disorders. Approximately in 40% cases of congenital anomalies, the anomalies seem to belong to the urinary tract. However, they not only manifest in the immediate postnatal period, but they could also have long-term consequences, and regarded as one of the commonest causes of end-stage renal disease in children and adolescents. And also further on, like polycystic kidney disease, for instance, can manifest much later after the third decade. So the exact etiologies of CAKUT are not well defined. But as time passed, we now recognize that they have both genetic and molecular level detail, which has now been understood. And I will be showing some of the slides related to these defects. Now, the deformities, like I said, which we will discuss today only belong to the kidney. We will not talk about the deformities that go with the lower urinary tract, right? That means we'll talk about the collecting system and some of the cystic lesions of the kidney. We also talk about those deformities which arise out of the embryonic migration of kidneys, and also about the renal parenchymal development. If you want to understand with some degree of significance the congenital anomalies, then I think we should also be reasonably good at the developmental aspects of the kidney. I will not perhaps be giving you a very detailed exposition on the developments, but here are some of the main features of the development. Kidney develops from the intermediate mesoderm. You must be remembering that from your embryological knowledge. And there is a ridge that forms, which is called the urogenital ridge. So the urinary components, they come from the one aspect, and the genital components come from another aspect. So the urinary components essentially go through three stages, which I have written down here: the pronephros, and the mesonephros, and the metanephros. Let's look at this thing in some detail. Pronephros, the point to remember is that all these stages of development start from the cervical and go on to lumbar and sacral. So therefore, the pronephros starts off in the cervical region and goes up to the thoracic region. The nephric duct, as well as the tubules which the pronephros develops, this is around the 4th week of gestation. They totally disappear. So therefore, we can leave it at that. Now the mesonephros, which is the next stage of development, this starts off in the thoracic region, goes off through the lumbar region, and up to the sacral area, right? So this has got a lot of importance, developing somewhere around the 4th, 6th week and going on till the 8th week, produces significant number of tubules, as well as a mesonephric duct. The tubules function for a while, do contribute to the amniotic fluid, and after that, they degenerate beyond a point, leaving behind the mesonephric duct. Mesonephric duct, also called the Wolffian duct, that is the one which contributes a lot to the male genitalia in particular. For example, it contributes the epididymal tubules, vas deferens, the seminal vesicles, and up to the level of ejaculatory duct. So mesonephric duct, the one shown here in the black, this is the sort of area that remains. The tubules, also called mesonephroid, they do degenerate. Now the mesonephric duct travels out from the, as I said, from the lower thoracic region and goes up to the cloaca, and it attaches itself to the cloaca. It does a lot of work there, which we are going to see in the next slide, next step. Now here is the situation. The mesonephric duct has gone into the cloaca. Cloaca itself gets divided into a urogenital component, and a rectal component, right? So once it gets itself attached to that part, to the cloaca, then the mesonephric blastema, which metanephric blastema, which is locally developed in the region of the sacral area, that blastema surrounds the ureteric bud, which arises from the mesonephric duct. This is the area, right? This is the ureteric bud, which is going into the metanephric blastema. Now, this is a very important stage because the entire development of the kidney will depend upon this particular stage. And we know the exact molecules that are that operate at this level, and further development, how it takes place. We'll talk about it in the next slide. And it is also very much known now, which are the genes which operate in this particular area. So going back to the talk that we are having, so ureteric bud coming from the lower end of the mesonephric duct will actually enter into the metanephric blastema. So now we are in the metanephric blastema, enters the metanephric blastema, and that metanephric blastema is what is going to form the parenchyma of the kidney. As you are seeing here, the ureteric bud goes through a series of changes, which I'll describe later, and that gets surrounded by the metanephric blastema, which finally ends up forming the kidney structure, the parenchyma. Now, what are the series of changes that happen in the ureteric bud? Ureteric bud, first of all, invades the blastema. Second thing is it goes up, it ascends. The third thing is that it elongates, right? Obviously, if it has to ascend, it has got to elongate. So this is stage 1, where it is getting into the blastema. This is stage 2, where it has just begun the first generation of division surrounded by the substance. And this is stage 3, where the parenchymal substance is already becoming lobulated and growing further. And this is stage 4, which has gone up to the collecting tubule. These are the various stages it goes through. And in this process, it also tends to ascend. So this is what we have to, and these are all very important, because the various anomalies that take place do occur in different stages of this kind of development. So in sum and substance, this is the renal development which pertains to the talk which I am giving right now. So we could have greater detail, and both about the genetic and molecular detail, which I am not going into.